I will be starting my topic, vitreous hemorrhage in a young patient, which is also going to be very interesting because I have a couple of cases that are going to be interesting for everyone. Next is Dr. Guru Prasad, all of our mentors. He is the head of Vitreoretina and medical director Joshi Eye Hospital. He is going to be talking about intraoperative surprises while operating for vitreous hemorrhage. Then we have Kumar sir, as we fondly call him. He is the director of Kumar Netralaya, Bangalore. He is a prolific VR surgeon and an expert in most areas of vitreoretina. He is also a pathological winner, physiological winner, and he wins most of the competitions he enters, whether it is papers or videos. And recently he has forayed into the world of publications also. And Dr. Kartikeya Singh is another dear friend who is going to speak on vitreous hemorrhage in a diabetic patient, but not everything is PDR. He is also a newly mushroomed prolific VR surgeon, and he's probably the highest, he's probably got the highest number of VR surgeries under his belt at his his age and his stage of his career, and he works for ASG Hospitals, Varanasi. So I call upon my first speaker, Dr. Giriraj.
Thank you, ma'am, for that kind introduction. Okay, so let me start with the first topic of this first session for today, vitreous hemorrhage and the normal fellow eye. So, definition kya hai? Somebody might ask the PG students who might be seeing this recording. So, definition kya hai? By definition, it is the presence of extravasated blood within a space which is lined posteriorly by the ILM, anteriorly by the posterior lens capsule, and laterally by the unpigmented epithelium of the ciliary body. So it can be either sub-ILM bleed, sub-hyaloid hemorrhage, or intragel hemorrhage. So in this beautiful article by Saxena and Dr. Subhadra Jalali et al., they classify vitreous hemorrhage based on its mechanisms. So some common mechanisms are retinal vascular disorders which cause ischemia, like ischemia leading to angiogenesis, which leads to vitreous hemorrhage. There are conditions of vascular anomalies where there is no ischemia, like rupture of a ram because of hypertension, bleed from an angioma, congenital arterial loops, etc. It can also be due to rupture of a normal vessel, as it happens in the retinal tears, in the retinal schisis, and PVD-induced vitreous hemorrhage and Valsalva retinopathy, etc. Another important cause in the old age people mainly is MNV or CNVM and peripheral exudative hemorrhagic chorioretinopathy and PCV being the most common amongst them. So just wanted to highlight the point, in pediatric age group, most common condition is trauma. I know Dr. APOORVA is going to speak in detail on this, so this is just a list, I will not go into that. So diagnosis for a vitreous hemorrhage patient, you start thinking about the diagnosis as soon as the patient enters your OPD. The patient may be having a puffy face, you have to look at his gait, he may be debilitated or he may be obese, and he may be having a bandage to his foot, or there may be a central line poking out of his neck. He may be looking pale, or he may be looking septic, for which he is being treated. So after that, definitely history is important, history of trauma. In rural population, and especially if you are taking history from women, you may have to take that in privacy because they may be afraid of telling the history of trauma in front of their relatives. Same thing applies to children also. They may be afraid to tell any history of fight in the school and all. Medical conditions, of course, most important, then history of any drug intake and history of previous surgeries. I want to highlight the point that after cataract surgery, if a patient is developing vitreous hemorrhage which was not there earlier, so you may have to think that if peribulbar anesthesia was given, there is possibility of globe rupture or needle perforation injury. So what is the checklist in case of VH? You have to look for any documented previous visual acuity, presence of RAPD for prognostication, and intraocular pressure. It may be low or it may be high. If it is low, you can suspect retinal detachment, or if it is high, you may have to look for neovascular glaucoma, etc. Look for neovascularization at the angles and at the iris. Lenticular opacities may help you in planning your management. Looking for lacrimal sac and adnexal evaluation, again, this is important. B scan is the savior in total vitreous hemorrhage cases. You may find presence of retinal hemorrhage or intraocular foreign body or any other pathologies which may not be obviously seen. So examination of the fellow eye, again, it is very, very important. If on the 90D it may seem normal, but there might be something which is sneaking in the periphery. There might be a in cases of trauma, there might be a small foreign body which might be missed in the other eye, or peripheral vasculitis can also be there, or a small peripheral tear will also be there. So indented examination of the other eye is a must. Coming to some of our cases, in this one point I wanted to highlight that in vitreous hemorrhage in a diabetic patient, there might be vitreous hemorrhage with TRD in one eye while the other might be normal. In this case, in the right eye, the patient has almost moderate to severe NPDR, and the left eye is completely normal, except for the pallor in the disc. So asymmetric DR, it is not so uncommon. It is seen in 5 to 10% of the patients with PDR. Again, in this beautiful article by Azad sir et al., they mention causes. Look at how carotid obstructive disease affects the progression of PDR. So if it is occurring before the onset of DR, it is protective. If it is occurring after the onset of DR, it is causing further increase in the ischemia, and it leads to further progression of the DR. Any inflammatory condition like uveitis, it is known to progress the diabetic changes, and degenerative changes like posterior vitreous detachment, chorioretinal atrophy, retinitis pigmentosa, etc. They are known to reduce the metabolic demand of the retina and therefore providing a protective effect against progression of PDR. So cataract surgery, of course, it will lead to breakdown of the blood retinal barrier, etc. Some of our cases, most common condition in hypertensives, we see branch retinal vein occlusion leading to vitreous hemorrhage. In cases of trauma, we have to look for GRTs or dialysis. In this, you can see the sutured cornea through which a wide field image has been taken. PCV, that is what breakthrough hemorrhage can cause. PCV can cause breakthrough hemorrhage, and of course vasculitis in young patients. So this condition, Dr. Guru sir is going to speak about it. I'll just leave this image for you, and sir will show an operative surprise for this patient. So what we do in such cases, we send the patient to physician for evaluation. We follow protocol at our institute that all vitreous hemorrhage cases, we get peripheral smear with CBC counts done before posting for surgery. So to look out for any leukemic changes or any anemic changes or sickle cell, etc. So systemic evaluation, if it needs to be done, the physician will look into organomegaly and pulmonary hypertension, etc. What is the fate of vitreous hemorrhage? It can clear spontaneously, and or if it is there for the long time, it may lead to hemosidrosis or retinal toxicity, glial and fibrovascular proliferation, or ghost cell glaucoma, etc. Earlier, it was recommended that you can wait till 6 months also, but nowadays we decide the management depending on patient status, whether the patient is one-eyed, whether he needs his visual acuity for his work, or how long to wait based on the pathology itself. So after establishing the etiology, then the management observations can be either you can observe, you can do laser photocoagulation, or you can plan a pars plana vitrectomy. So in cases, observation, fresh vitreous hemorrhage often clears in days to weeks, and if you can see the retina through the vitreous hemorrhage, you can take a call based on that. If there is no presence of retinal detachment or an infection, you can wait for the vitreous hemorrhage to clear, and you should start PRP laser as soon as some part of the retina is visible to you. So role of vitamin C in or ascorbic acid in the patients of vitreous hemorrhage, again, the role is not proven that it helps in absorption of vitreous hemorrhage, but its role has been proven in people who are having deficiency of vitamin C. Scurvy leading to vitreous hemorrhage is also reported, and role of vitamin C in prevention of macular ischemia has been reported. So PDR patients, there is no harm in giving vitamin C for prevention of macular ischemia. So laser, yes, of course, it is done, and even if you are suspecting PDR, it is always good to do an indented examination and look for associated retinal break or horseshoe tear. Vitrectomy, common indications are non-resolving VH and patient needing early recovery, RD or presence of endophthalmitis. Again, vitrectomy in an open globe injury is a debatable topic. Some people say you can do it at the primary setting or you can do it later. Later helps in, there will be PVD then the vitreous hemorrhage will be easy to clear, and you will have a firm globe also. So I think I'm in time. Thank you for this opportunity.
So this was like this was pretty taut here. So I was suspecting an incarceration at the site of the scleral tear. Now this was the surgery. There was a total chamber hyphema, and despite repeated washes, it was still continuously oozing and hence filling up again. So I did a lensectomy, placed the infusion, I made sure it's in place, and went in. And this is for most of us who operate on trauma cases, this is like a textbook finding. We have dense multi-layered vitreous hemorrhage, clotted blood, and we are always going in with a lot of trepidation because we don't know what we are cutting, whether it is vitreous or retina. We just you just get the feel of the tissue. You start seeing the retina there, and if it moves very fast and this thing, it's probably vitreous. So like you can see, this is a partial PVD that has happened, and we can see the retina underneath it, and it is already detached. So while I was clearing the vitreous hemorrhage, it was obvious that it was still bleeding because it's a congested eye after all. There were some breaks, inferiorly large ones, and as I cleared the vitreous hemorrhage, this is the finding that I saw at the optic nerve. There was an avulsion for sure. You can see that there is retraction of the optic nerve head from the ring, and I filled PFCL both because the retina had a GRT almost 360 degree as well as a continuous bleeding. So now here there was this site of incarceration of the retina with a lot of scarring at the site of scleral tear. So what I did was I isolated the scar from the rest of the retina. You can see that this is the retina, and I've isolated the scar to prevent reproliferation. And as I was doing the retinectomy, I was finding that it was still continuously bleeding. The choroid was bleeding, the retinectomy margins were bleeding. So I have left the globe PFCL filled. I operated on this last week, and I'm going back to see after 2 weeks, at which point I'm sure it will be much easier to handle. So in trauma, you have multi-layered, thick, clotted vitreous hemorrhage. The light pipe is difficult to visualize, especially in the initial part where it is obscured. We don't know what we are cutting. Surprises, it's a Pandora's box, so it can be anything inside. It can have an RD, it can have incarcerated retina in the scars like I showed. There can be a foreign body, there can be infection, endophthalmitis. There can be ruptures of the choroid with scarring, and of course, like in my case, optic nerve avulsion. So the visual prognosis has to be explained to the patients in no uncertain terms. In a trauma, it is a Pandora's box. You can have anything. So this is my next case. We'll come to the non-traumatic vitreous hemorrhages in young people. This is a 16-year-old boy with diminished vision in the left eye more than the right eye. Right eye had a vision of 260 and left had half by 60. There were a few granulomatous KPs in both the eyes. Now this was the right eye. We could see some chorioretinitis, and they were straddling the veins. There was vitreous hemorrhage in the right eye, and there was this kind of vitreous hemorrhage in the left eye with this severe chorioretinitis. In fact, it is more of retinitis with severe cuffing of the supratemporal vessel, the peripheral vessels, and the nasal retina, showing some kind of frosted branch angiitis picture. So we did do a uveitis workup, and we started on systemic steroids. After 2 days, there was a slight improvement with steroids. The only thing that came up positive was a MAN2 test. As we know, according to the courts, this is grounds for starting ATT anyway, because tubercular retinal vasculitis is one of the hallmark diseases of ocular tuberculosis. So with steroids, we can see that the cuffing has reduced. Even this has started developing hemorrhages. The frosted branch angiitis is getting better. 1 week later, we also started ATT in view of the diagnosis of TRV. So we decided to taper by 5 milligrams every week, and this was the picture. We thought he's slowly getting better. But at 1 month of steroids and ATT, the right eye, although it improved, the left eye had a sudden diminished vision with counting finger close to face. We planned to observe because there was only a partial PVD on the V scan, and planned a vitrectomy after complete PVD. So this is what happened. We could see the disc hazily, but the vision was very less. So Rohan, I'm sure you remember this case. He actually managed this case from start to finish, including the surgery was done by Rohan. So this was vitrectomy and endo laser, and this was air filled, and this was post vitrectomy, and the patient had undergone endo laser for all the areas of non-perfusion that were seen intraoperatively. The vasculitis started getting better. The patient continues to do well on ATT and low dose steroids. This is at 3 months follow-up. So what I want to say is retinal vasculitis can have simultaneous presentations of all the stages of vasculitis, ischemia and neovascular stages. They can all present together. But it is also important to know that not all vitreous hemorrhages are because of neovascularization. Like in this case of post-fever retinitis, who sometimes develop vitreous hemorrhage, and that could be because of neovascularization. It could also be because of inflammation inducing posterior vitreous detachment, or it can be a detachment causing avulsion of a venule, a taut venule. This is the next case. 31-year-old woman, postnatal day 4. She had just delivered her third baby, and she had diminished vision since the day of vaginal delivery. So this was a case of preeclampsia. Right eye vision was just counting finger close to face. Left eye was absolutely normal. We worked her up. She was found to be anemic with some microalbuminuria and some probably UTI, we don't know. D-dimer was severely raised. So we corrected her anemia and planned a vitrectomy under steroid cover because her D-dimer was very high, and we sought physician fitness. She developed a breakthrough hemorrhage meanwhile, and we saw that her blood pressure was not getting controlled no matter what. Slowly the vitreous hemorrhage became more diffuse, and this nasal subhyaloid hemorrhage started settling down and trickling down, although this vitreous hemorrhage was looking like it is progressing. But it has broken through. So now at this point NVD is visible. So this was on the day of surgery. Post-surgery, we did find intraoperatively that there were multi-vessel or multi-vein occlusions, and this is the post-op picture. She's doing well now. She's about 6'9" and very happy with her vision. This was a consequence of accelerated hypertension, perhaps. I'm still not sure of the diagnosis. This was post-delivery, young woman, multi-vein occlusions, high blood pressure, raised D-dimer. I'm still caught between whether it is post-inflammatory or a sequelae of retinal vein occlusion. This is a very interesting case of a 38-year-old woman with diminished vision in the right eye for 5 months. She's a person living with HIV/AIDS on maintenance therapy for pulmonary tuberculosis. Vision in the right eye was hand movements, and left eye was absolutely normal. And the right eye had large mutton fat KP and broad base posterior synechiae with very restricted view of the fundus. You can see this leopard mottling here with plecoid lesion, and this had attended and another feature of vitreous hemorrhage as well. So we did do her uveitic workup and found that TPHA was also positive along with HIV, as we already knew. So we diagnosed this as a case of syphilitic chorioretinitis based on the investigations, the leopard mottling and vitreous hemorrhage also. Vitreous hemorrhage, I have learnt, is caused by syphilis as well. So now this patient did better inflammation wise. The granulomatous KP and the uveitis part, anterior uveitis part started getting better. And in fact, it got a lot better with 20 days of IV cephalosporins. But what she developed was progression of the vitreous hemorrhage. There was a large clot here inferonasally, and there was diffuse vitreous hemorrhage, this subhyaloid hemorrhage. So that is a little uncommon. Finally, at this point, she has dispersed vitreous, breakthrough vitreous hemorrhage, which is more diffuse right now, and the uveitis part is nearly resolved. This is the last case of a 19-year-old boy with painless loss of vision in both eyes since a month. So there was history of some head trauma which may or may not be related. He's been treated for allergic conjunctivitis with topical steroids for a very long time and has received IV treatment with antibiotics 2 weeks ago. So both eyes, perception of light and 360 degrees fanus-like picture with some very gelatinous membrane sort of thing at the limbus in both the eyes. This was a fundus examination. Both the eyes images are unclear because of poor fixation as well as vitreous haemorrhage. So the right eye OCT was possible, and this diffuse thickening of the inner layers was seen, suggestive of retinitis. And the patient was HIV and HbSAg positive with some mild anemia. Next day he told us the whole story because they are not initially forthcoming of their history. So he is on heart and treated for cryptococcal meningitis. So this was a case of bilateral CMV retinitis with very low CD4 count and even had the finding of bilateral OSSA. So post-treatment with ganciclovir intravitreal, the vitreous hemorrhage started to resolve and he did start to get better. So this was a case of severe hemorrhagic CMV retinitis with vitreous hemorrhage. Now my last slide, like I said, trauma can be a Pandora's box. Infants and children in non-accidental trauma, shaken baby is one of the important causes. Rarely they can be tumors. Vascular retinopathy, we still have to rule out diabetes and hypertension and common metabolic conditions. Post-infection and inflammations like I have shown. Terson's, Valsalva, we have to ask the right questions and ask them to recollect these histories, and we have to keep in mind blood disease, sickle cell and leukemia. So I call upon my next speaker, Dr. Prasad, who will speak about intraoperative surprises.
This IC and Dr. APOORVA for including me in the list of the faculty slides. So in the morning every day on the surgery day we have a discussion for about half an hour about. In the case of vitreous hemorrhage, we usually ask our residents what are the possibilities, especially when we don't know what the cause of vitreous hemorrhage is, and usually have a list of differential diagnosis. But many times the actual condition which would have caused the vitreous hemorrhage would be different from the list. It would not be in the list of the differential diagnosis, and that is what I'm going to talk about. A mix of those in the differential diagnosis list and those which are not. So this is a case of a 59-year-old gentleman, 12 years, diabetic, sudden loss of vision, right eye, low view due to vitreous hemorrhage. So 12-year diabetic, you know that it is usually a PDR that has caused the vitreous hemorrhage. The B scan showed a retina attached, no proliferation seen. The other eye showed mild to moderate NPDR changes, or maybe severe NPDR changes, all the more giving us reason to guess that the cause of vitreous hemorrhage is PDR in this eye. So anti-VEGF was given. It was at a time when we were giving routinely 5 years ago or 6 years ago. Nowadays we don't give anti-VEGFs routinely for all vitrectomies, and vitrectomy was done. And on the table we found that there was no retinopathy, not a single dot hemorrhage or a microaneurysm in this eye with vitreous hemorrhage. And then we had to indent and see the periphery, and we found a small peripheral HSD along the vessel, which was actually the cause of vitreous hemorrhage. So it need not always be diabetic retinopathy. We have retinopathy in the other eye, we have a history of diabetes, and we always presume that this could be vitreous PDR, but this case showed that it sometimes can be wrong. So, and lessons from this case: anti-VEGF was not needed. History of flashes probably could have helped and could have been elicited. A small flap could have been looked for on USG on careful examination, and a post-operative FFA for a clinically normal fundus is something that we should think about to rule out a PDR in this eye which looks normal, something like a featureless retina which we might be dealing with. Case 2, loss of vision in the left eye of 1 week's duration. No systemic illness, B scan, no RD. He was advised and underwent surgery, and this is what we found on the table. Retinal detachment with, a large tear, and this is the tear that is being lasered. So the RRD was found intraoperatively. No systemic illness, no history of trauma, nothing, and this is what we found. So this is another surprise that we had, or unexpected eventuality that we had on the table. This again is an ochre-colored blood, which is a breakthrough hemorrhage from a peripheral VSCR that we diagnosed intraoperatively. In the case of vitreous hemorrhage, the B scan was not available with us. The patient was refusing a B scan because he had undergone a B scan elsewhere, and that B scan showed only the posterior pole, which was not showing any retinal detachment or a mound. So this is what we found on table, and it was managed, no doubt. If we had probably anticipated that there was a peripheral exudative hemorrhagic retinopathy, we would have probably managed it in a better way, but we ended up with a large tear, which we fortunately could manage well. So never venture without a USG report from outside. This is a lesson that we learned from that patient. Case 4 is of a 50-year-old female with no systemic illness, gradual loss of vision since 3 months, vision reduced due to vitreous hemorrhage, and posterior synechiae was present. You can see the posterior synechiae in this eye. There was vitreous hemorrhage, and the disc was hazily seen. Ultrasound showed no retinal detachment. So this is the video of the patient who undergo with the uveitis signs in the anterior segment posterior synechiae. And you can see the fundus is nearly normal, but when we looked at the periphery, we found this scleron-like appearance. We induced a PVD, did a posterior vitreous detachment induction, and you can see those white dots. Some of them are actually IVT crystals, but most of them are inflammatory deposits on the retina. We did an indented base shaving and found that there was no evidence of vasculitis or vascular abnormalities. This again is a diagnostic diagnosis. We don't know the cause of vitreous hemorrhage. This could be just a PVD causing a vitreous hemorrhage in a uveitis patient, coincidental to the uveitis. So this is another case which teaches us a lot of things. Case 5, a 62-year female with sudden loss of vision, 1 month, diabetic since 10 years, other eye severe PDR. When this is the status of the other eye with severe PDR, we would expect that the other eye also would have a PDR. But during vitrectomy, what we found was something else. We found that there was no diabetic retinopathy, like in the first patient with the retinal tear. This was actually a case of superior temporal BRVO with no diabetic retinopathy changes. In fact, there was no neovascularization to explain the cause for the vitreous hemorrhage, and probably this was a case of PVD. We really don't know what the cause of vitreous hemorrhage was, although we presume that this could be due to a BRVO. So this is the fundus finding. We did a laser, no doubt, just to overdo and see that there is no scope for further bleeding. Case 6 is another case of vitreous hemorrhage in a phakic eye. You can see the vitreous space being filled with blood, and this is what we found on table. A large hemorrhage, subretinal hemorrhage, sedation, and elevation of the retina. So this is something that we can have, and if a proper ultrasound is done before the surgery, we can pick up these findings. So PCV with breakthrough hemorrhage is what this patient had. Post-trauma with RD on USG is something that we had in the beginning of the surgery. We saw that there was RD, but this was more than a month old, and there was this incarceration of the retina, which could not be detected on the B scan. So maybe it was a very small scleral tear into which the retina had got incarcerated, causing RD, and this was something that we had to relieve by retinectomy, and I'm sorry about the poor video, but then that was what it was. Other coincidental findings that we may have on during vitrectomy are macular hole, like in this patient. bileum peeling, you can have ERMs, you can have EMT, you can have intraoperative multi-layered hemorrhage in a breakthrough vitreous hemorrhage in RAM patients, which are also coincidental findings during vitrectomy, which we would not have diagnosed before surgery. Masquerades of DR are another set of causes of vitreous hemorrhage. Anemia, myeloproliferative disease, and so on are very, very common. And like Dr. Viraj mentioned in his talk, we have to evaluate these patients. At least a CBC, total blood count, helps us a lot in eliminating the likely cause of a myeloproliferative condition. So, in summary, the vitreous cavity is a cavity of uncertainties. Preoperative diagnosis is a challenge. In some patients, you can never be sure of the cause every time, and surprises are quite common. Thank you very much.
The actual author of this IC. Thank you, sir, for giving us this idea. It's turning out to be a good IC, I think.
Thank you. Thank you, Dr. Apoorva, for giving me a chance to be presenting in this instruction course. My topic is vitreous hemorrhage from macular pathologist. Much of what I'll be speaking has already been discussed in one or the other form by the preceding speakers, but we'll just go through this. So most cases of vitreous hemorrhage from macular pathologies are usually the breakthrough bleeds, or what I have termed this as an implosion, whereas where the pathology is within the retina, and then it's a kind of an inside out kind of a mechanism by which the blood from the subretinal space under pressure, when the volume of the blood is too much, rips through the retina, and then you have a vitreous hemorrhage. Common causes for such an occurrence are wet ARMD, and broadly in wet ARMD, PCV and RP rips are the main causes for such breakthrough bleeds. Retinal arterial macroaneurysms, Terson syndrome, which has been alluded to, blood dyscrasias, Valsalva maneuver related vitreous hemorrhages, although they may not strictly be macular related. Then choroidal melanomas, particularly the collar button type, where the strangulation or the tourniquet affects at the level of the Brooks membrane, causes the surface of the tumors to be congested, and then they can bleed. Rarely macular NVs from vein occlusions or PDR. And an interesting report in the literature about the use of ginkgo biloba in patients with other issues has been shown to be a cause for which there is an isolated case report where the vitreous hemorrhage was probably linked to the use of this because it contains a certain inhibitor of platelet activating factor. So I will not go through this. So the diagnosis is broadly based on the preceding history. If it is available, will be very handy in such patients, and then we have to seek recourse to investigative modalities in the form of ultrasound, B-scan, OCT, FFA, and ICG. So this is an ultrasound picture of a patient who has had a vitreous hemorrhage due to a macular bleed, submacular bleed. So the prognosis in these patients is generally poor, as can be imagined, due to the coexisting pathologies, and the treatment would consist of vitrectomy and allied procedures. We may have to keep subretinal TPA handy for use subretinally. Pneumatic displacement of submacular hemorrhage when the cause is not very obvious, and then of course if it happens to be a melanoma, then treatment as deemed appropriate. So I'll go through a few cases. These are some pictures related to Valsalva related vitreous hemorrhages in patients who had joined fitness programs and had also associated dehydration as a factor in these hemorrhages. Usually these hemorrhages clear well without any treatment. Of course, one must not assume that it is a Valsalva retinopathy and forego the other methods of investigating the cause for a vitreous hemorrhage. These are more examples of the altered color of the blood as the blood resolves in patients with Valsalva hemorrhage. This is an interesting patient who presented with floaters in one eye. His preceding image in the fundus was like this. He had a ring of hard exudates here. We thought it was related to diabetes, but subsequently there was nothing on the corresponding fluorescein angiogram, but subsequently he presented with floaters and this massive submacular hemorrhage with a nice infarct distal to the probable site of a macroaneurysm in this patient there. We did a pneumatic displacement of the subretinal hemorrhage, and that was the ultimate picture, although the patient had very poor vision from macular ischemia. This is yet another patient of retinal arterial macroaneurysm who responded very well to pneumatic displacement of the hemorrhage. The underlying cause in most cases is systemic hypertension, many times undetected. So we will have to be aware of this possibility. This is a patient with PCV who developed massive breakthrough vitreous hemorrhage, and intraoperatively we had to resort to vitrectomy. And intraoperatively there was this large amount of subretinal hemorrhage. She was not willing to have TPA injected, and we just injected anti-VEGF Eylea in this patient post-operatively, and that is the unfortunate outcome of this patient. So whenever there is a breakthrough bleed, it usually has a poor prognosis, and we end up with these large disciform scars. This is another patient with a PCV who presented initially with this. I'm presenting this to show that initial quiescence may not always be a hunky-dory story in these patients. So he responded very well to initial Eylea, and the OCT also seemed to be relatively quiescent. But he developed this massive submacular hemorrhage about a year later, and then a breakthrough vitreous bleed as well. But he was not willing for surgery. We continued with anti-VEGFs again, and these are the pictures in the end. He fortunately retains reasonably good vision, 636, despite the hurricane course within the eye. Now these are other examples of PCV treated with pneumatic displacement. This is a patient of malignant melanoma of the eye. He was lost to follow-up, and he had vitreous hemorrhage as well. These are pictures from the net which show the choroidal malignant melanoma of the NAPRON type. This was a patient who had bilateral macular hemorrhages following a road traffic accident, and had also intracranial subarachnoid hemorrhages, Terson syndrome. Of course, as I was saying, many patients with an isolated branch retinal vein occlusion with a new vessel along the upper temporal or the lower temporal arcades may also have macular bleed, and these patients need to be treated with appropriate lasers, or even diabetics with a macular NVE within the arcades can bleed, and then we treat them usually with a PRP. More examples of PCV here again. This is an interesting patient. This patient came with vitreous hemorrhage, for which we did a vitrectomy, and I don't know, the pictures are not very clear on the screen. It's quite okay here. Intraoperatively we found massive submacular hemorrhage, which was just short of the fovea, and these are the pictures post-op: altered vitreous hemorrhage altered subretinal hemorrhage, which is progressively turning yellowish and brownish. But what we found was this large RPE rip much later during the follow-up. We really couldn't identify this even intraoperatively, and this is the final picture of this patient. A trauma was being referred to as a cause of vitreous hemorrhage, but this patient, the point I was trying to make was, in patients less than 40 years of age, most common cause of a vitreous hemorrhage is trauma. That is an important piece of information that we must remember. This was a 39-year-old person who presented with vitreous hemorrhage. The other eye was normal. He did not give any history of trauma despite our repeatedly probing it. And intraoperatively, he had this large giant retinal tear with a macular hole as well, definitely related to blunt trauma. And then post-operatively, when we told him that there were definite evidence of blunt trauma related injury, he then confessed to having had a fight some time ago. So these are some of the things that we should be aware. Blood dyscrasias causing macular hemorrhages, and this was the patient with vitreous hemorrhage due to that large RPE rip. In most cases with breakthrough bleed, in my limited experience, I have found that the vitreous is somewhat fibrinous and somewhat stringy, and once we did that vitrectomy and reached the retinal surface, this was the subretinal bleed, and since the edge was just below the fovea, we decided not to do anything, because in the process of injecting something subretinally, then we may detach and the fovea may get detached. So as it turned out, it was due to a large RPE rip in this patient. And it was just short of the fovea. Thank you very much for your patient hearing.
is Dr. Karthike. He's going to talk about how vitreous hemorrhage in diabetics is not always because of PDR.
Good morning, Good morning, everyone. Thank you, Dr. Apoorva, ma'am, for giving me this IC, and it's a privilege for me to stand with all my mentors here and talk in this IC. I'll just start with my presentation. So we have seen everything till now, from intraoperative surprise to macular pathology causing VH, and now I'll be talking about vitreous hemorrhage in diabetics, but not everything is PDR. So when to suspect? When you see a unilateral picture, grave systemic look, history of trauma, these are three major things which make you suspicious that this could not be a PDR causing vitreous hemorrhage. So I'll be talking about cases directly, and we'll deal about that. And case 1, you can see that there is a vitreous hemorrhage in one eye, and there was some hard exudate with some blot hemorrhages in the other eye. Look like a PDR in this eye. So, however, vitrectomy and PVD with vitrectomy was done, and we found that there was a falsehood tear causing this vitreous hemorrhage. And the important history here was history of floater. So, I don't have the video for that, but I'll show the videos in the next cases. Case 2 is a 51-year-old male, diabetic since 10 years, nil other systemic history, right eye dense VH, left eye mild and PDR. Differentials were again unilateral PDR, old RVO. So we went with the surgery. We saw a very altered hemorrhage, very dense vitreous hemorrhage. But yeah, in the periphery, I could see retina was on and everything was settled. We could not see any evidence. I even did indented examination to see if there is anything peripheral causing the bleed. And this patient was very high, had a very high expectation. I was just showing the IOLC had PVD IOL placed in the cataract surgery done by other surgeon. And this was nothing but a case of PVD induced VH, only mild and PDR. I could not show very few blot hemorrhages were there near the posterior pole. In the third case, 57-year-old male, left eye dense VH with there was fibrovascular proliferation kind of picture on B scan. Right eye only few blot hemorrhage was there. Again, I'll show you the intraoperative finding. So we went ahead and we did vitrectomy. There was like a lot of blood in the behind the lens in the anterior vitreous face, so I was clearing it. And then after clearing it, I could see a scar near the posterior pole. It was nothing but a case of occult tear. So I could not find anything related to PDR leading to vitreous hemorrhage here. Again, there was some blood in the anterior vitreous face, which I could clear properly, and the laser was done to the scar. The case was closed. So this was a case of occult posterior rupture, and trauma was unknown, but he could recollect later that okay, there might be a trauma, but still he was not very sure. Case 4 is a 65-year-old gentleman diagnosed as bilateral vitreous hemorrhage secondary to PDR, posted for vitrectomy. So this was an intraoperative picture, multi-layered hemorrhages, angry-looking hemorrhage all around with some. I don't have the video for this, but when we did investigations, we found that there was a chronic myeloid leukemia. WBC count was 50,000 with myeloblast in peripheral smear. There was mandatory CBC with peripheral smear. That's why we say that there is, the sir was also pointing out what is the importance of peripheral smear in these cases. And when you see this vitreous hemorrhage of unknown origin, and deep hemorrhages, increased intraoperative bleeding, all these are the intraoperative findings which you see in these cases. In my fifth case, left eye PCVA was only CS counting finger close to face, and rest everything was almost okay. So So this was the fundus photo which we drew in the OPD, and there was subhyaloid hemorrhage in the other eye, and with vitreous hemorrhage, dense vitreous hemorrhage in the left eye. This was the OCT of right eye showing a ARM with traction kind of picture with some SRF. This is the B scan of the other eye, left eye, and if you see, there's a dense hemorrhage with, they put the possibility of FBP attached to the disc with taut posterior hyaloid, and this is the intraoperative find.
Karthikeya, we have 3 minutes.
No?
Only 2 minutes more.
Okay. Yeah, just last case. So, what we found here was a peripheral smear with microcytic hypochromic blood picture, and the other investigations were almost okay with mild anemia. And when we did a detailed investigation, we found elevated HbA1, HbA2, a beta thalassemia trait. So, in my sixth case, 60-year-old male with sudden DOV in right eye of 1 week. Right eye there was PDR with VH, left eye lasered PDR, posture for vitrectomy in the right eye, and dense vitreous hemorrhage, and there was a RAM which we found. It was cut out and laser was done around it, and the patient is doing okay. Retinal artery macroaneurysm was there, which was fibrosing at the summit with, and bimanual dissection was done for that. In the last case, I'll just go through this case. 50-year-old lady with both eye DOV, history of fever 2 months back, consulted ophthalmologist, and she was told that she has retinal problem and advised to take tablet Visolone. She was taking in the tapering doses. Uncontrolled diabetic, dengue, chikungunya, wheel fillings, everything was normal, and CBC was normal. This was the picture which we saw, and there was like kind of retinitis with cotton wool spot and some edema on the posterior pole. Visual acuity was 6/9 and 6/18, and vitreous has some cells. In the right eye it was +1 and in left eye +2. This was the OCT finding which we saw a highly reflective inner layer of retina with retinitis, which we could see. And HbA1c was almost 8.1. She was started on doxycycline 100 mg 12 hourly and prednisolone 1 mg per kg with the tapering doses under patient supervision. She was gradually improving. The right eye was improved to 6/12, but the vision was not very well affected. And this was 6 weeks later. She is still improving, but now she is developing some vitreous hemorrhage in the other eye. And again, there was some kind of fibrovascular proliferation going on in the left eye 2 months later. Then even the peripheral laser was done. You can see some subhyaloid hemorrhages here. She was planned for surgery after this. That's because I have only 1 minute. And then after that she was lost for follow-up. She was planned for surgery in the left eye following intravitreal bevacizumab. And we could not get a picture. So what was this? This was a case of acceleration of vascular retinopathy, a COVID-associated vasculitis with extensive and neovascularization, COVID retinitis plus diabetic retinopathy, a double trouble. So again, the importance of peripheral smear can reveal so many mimickers, leukemia, hemoglobinopathies, myeloma, platelet anomalies. My take-homes are: keep an eye out for comorbidities like leukemia, uncontrolled hypertension, keep differentials in mind. Not everything is PDR. Other pathologies must be lurking around, and there should be a global approach for these patients. Thank you so much.
Thank you very much, Karthikeya. Because we did show a lot of very interesting cases on a single topic of hemorrhage. So we must congratulate ourselves. So thank you so much to the audience who made it to the IC at 8 AM in the morning. It really means a lot to us, and we hope to replicate such an IC in the next meetings. Thank you.